The safest blood pressure after 60 is probably not the number you were taught years ago. It is not automatically 140 over 90. It is not 150 simply because you are older, and it is not exactly 120 over 80 every minute of every day. For many healthy, independent adults over 60, the safest treated blood pressure zone is an average below 130 over 80, often with the top numbers somewhere in the 120s, provided that pressure is well tolerated. But those final words matter. A reading that protects one person from stroke may make another person dizzy when standing. A target that is appropriate for an active 65-year-old may need to be adjusted for an 88-year-old with frailty, recurrent falls, dehydration, or a limited life expectancy. That is why the safest blood pressure is not merely a number. It is a number your brain, heart, kidneys, and balance system can tolerate safely. In this video, you will learn what the latest heart guidelines actually recommend, why 145 over 72 is still high blood pressure when a low reading becomes concerning, how to identify a dangerous standing pressure drop, and how to create a 7-day record your doctor can genuinely use. Stay until the end, because the most common blood pressure mistake after 60 is not always having a number that is too high. It is making medication decisions from one inaccurate reading. A quick note before we begin. Senior Insight Guide provides general education, not personal medical advice. Nothing in this video is a diagnosis or prescription. Never stop, skip, double, reduce, or change the timing of a blood pressure medication without speaking with your doctor or pharmacist. Before we continue, tell me your age and the blood pressure number you see most often at home. Consider an illustrative example. Imagine a 72-year-old man named George. George checks his blood pressure occasionally at a pharmacy machine. His usual result is around 146 over 74. He does not worry about it. His lower number is normal. He feels reasonably well, and someone once told him that a systolic pressure in the 140s is acceptable after 70. Several months later, George visits his clinician. His office pressure is 152 over 76. George says, "That is normal for my age. The bottom number is fine." But the clinician does not agree. She asks George to use a validated upper arm monitor at home for 1 week. He rests before each measurement. He keeps his feet flat. He supports his arm. He takes 2 readings, 1 minute apart. His home average is 147 over 73. The lower number remains respectable. The upper number does not. George has a pattern known as isolated systolic hypertension. The systolic pressure is high while the diastolic pressure is not. After 50, the systolic or top number generally becomes the stronger indicator of cardiovascular risk. Large arteries tend to become stiffer with age, which can drive the top number upward even while the lower number stays normal. George's mistake was understandable, but it was still a mistake. The bottom number did not cancel out the top one. Blood pressure is written as 2 numbers. The first is systolic pressure. It is the pressure inside your arteries while the heart is contracting and pushing blood forward. The second is diastolic pressure. It is the pressure remaining inside the arteries while the heart relaxes between beats. Think of your cardiovascular system as a garden hose connected to a pump. The systolic number represents the pressure created when the pump pushes water through the hose. The diastolic number represents the pressure that remains while the pump briefly rests. Both numbers matter, but after 50, the systolic number often becomes especially important because aging arteries may lose some of their elasticity. That means a reading of 148 over 72 is not automatically reassuring. The 72 does not erase the 148. Either number can place a reading in a high blood pressure category, according to the 2025 American Heart Association and American College of Cardiology guideline. Normal blood pressure is below 120 systolic and below 80 diastolic. Elevated blood pressure is 120 to 129 systolic with diastolic below 80. Stage 1 hypertension is 130 to 139 systolic or 80 to 89 diastolic. Stage 2 hypertension is 140 or higher systolic or 90 or higher diastolic. Severe hypertension is above 180 systolic and or above 120 diastolic. Notice the word or. A reading of 142 over 76 qualifies as stage 2 because the top number is 140 or higher. A reading of 126 over 86 qualifies as stage 1 because the lower number is between 80 and 89. Both numbers count, but those categories are not identical to your personal treatment target. A category describes where the reading falls. A treatment target describes where your healthcare team is trying to bring your average pressure based on your risks, symptoms, health conditions, and tolerance. That difference is essential. For many adults over 60, the most defensible general answer is aim for an average below 130 over 80, often with systolic pressure in the 120s, as long as the treatment is well tolerated. The 2025 US guideline recommends an overarching treatment goal below 130 80ths for adults with high blood pressure. The 2024 European guideline recommends a systolic target of 120 of 129 for most patients taking pressure-lowering medication, but specifically allows a less intensive approach for those who cannot tolerate it, have orthostatic symptoms, are over 85 with frailty, or have limited life expectancy. In everyday language, many people will see a well-controlled result, such as 124 over 74, 127 over 76, or 129 over 78. Those are examples. They are not prescriptions. A reading of 118 to over 68 may also be completely healthy in someone who feels well. A reading of 132 over 78 may require observation rather than panic. And a reading of 122 over 70 may be too low for a particular person if it repeatedly causes dizziness, fainting, blurred vision, or falls. The safest number is not simply the lowest number. It is the lowest appropriate pressure that reduces cardiovascular risk without producing harmful symptoms or complications. Blood pressure often rises with age. That does not mean the increase becomes harmless. There's a difference between common and safe. Gray hair is common with aging. Arterial stiffness is common with aging. Neither fact means a systolic pressure in the 150s should automatically be ignored. Current U.S. guidance does not give otherwise healthy adults permission to remain at 150 systolic merely because they have reached 60 or 70. Its general treatment goal remains below 130 80ths. So, with individual considerations for people whose health circumstances make that target inappropriate, why does that matter? Because persistent high pressure is not merely a number on a cuff. It is repeated mechanical stress against the lining of your arteries. Imagine bending a garden hose while forcing water through it under excessive pressure. The hose may continue working, but the internal stress is higher. Over years, uncontrolled pressure can contribute to stroke, heart failure, coronary disease, atrial fibrillation, kidney disease, cognitive decline, and other cardiovascular complications. You may feel perfectly normal during that process. High blood pressure frequently produces no obvious warning symptom. That is why accurate measurement matters more than how fine you happen to feel. Some people treat 120 over 80 like a pass or fail examination. If the reading is 121 over 79, they become anxious. If it is 118 over 81, they assume everything is perfect because the top number is low. If it is 130 over 79, once they believe their medication has failed. The body does not work that way. Blood pressure changes throughout the day. It can rise temporarily during physical activity, emotional stress, pain, conversation, caffeine use, smoking, a full bladder, or an incorrectly performed measurement. The goal is not to force every individual reading to remain identical. The goal is to understand the average pattern. That is why current guidance emphasizes home blood pressure monitoring, standardized technique, and repeated measurements rather than relying on one hurried clinic result. One unusual number is information. A repeated pattern is evidence. Do not adjust your medication because of one result unless your healthcare team has given you a specific written plan for that situation. This is particularly common among older adults. A person sees 158 over 74 and says, at least the bottom number is good. But after 50, systolic pressure generally provides more information about heart and vascular risk than it did earlier in life. Large arteries become stiffer. They do not expand as easily when the heart ejects blood. The top number rises. The bottom number may stay normal or even become relatively low. This creates a wider gap between the two numbers, known as pulse pressure. The important point is not to calculate a new diagnosis at home. It is to stop dismissing a high systolic number. A repeated reading in the 140s or 150s deserves medical evaluation even when the lower number remains in the 70s. The top number is not the unimportant half of the reading. After 60, it may be the number demanding the most attention. Now we move to the other extreme. Some people become so determined to reach a low number that they stop paying attention to symptoms. They see 104 over 58 and feel proud, even though they become dizzy every time they stand. They see 96 over 54 and assume it must be excellent because it is lower than 130 over 80. But low pressure can become a problem when the brain and other organs are not receiving adequate circulation. The American Heart Association described hypotension as pressure below 90/60ths, but it also emphasizes that a low number is not automatically harmful when the person feels well. Symptoms such as dizziness, confusion, nausea, fainting, fatigue, blurred vision, headache, or palpitations make a low reading more concerning. This is where individual tolerance becomes important. One person may naturally function well at 98 over 62. Another may become unsteady at 112 over 64 because that represents a large drop from their previous pressure or because their pressure falls further when they stand. Do not judge low blood pressure from the number alone. Judge the number together with symptoms, posture, hydration, medication timing, heart rate, and medical history. Your pressure while seated may look excellent, but what happens when you stand? When you rise, gravity pulls blood towards your legs and abdomen. Your nervous system normally responds by tightening blood vessels and adjusting the heart rate so that enough blood continues reaching the brain. That response can become slower with age. It may also be affected by dehydration, diabetes, Parkinson's disease, autonomic disorders, heart conditions, and medications. Orthostatic hypotension is defined as a sustained drop of at least 20 millimeters of mercury in systolic pressure or at least 10 in diastolic pressure within 3 minutes of standing. It becomes more common with age and may cause dizziness, weakness, blurred vision, instability, or fainting. Imagine a person whose seated pressure is 128 over 74 that looks controlled, but after standing, the pressure falls to 104 over 62 and the person becomes lightheaded. The seated number did not reveal the full problem. This does not mean everyone should perform unsupervised repeated standing tests, particularly when they are at risk of falling. But tell your clinician when you experience dizziness after rising, darkening vision, leg weakness, near fainting, actual fainting, unexplained falls, or the need to grab furniture after standing. Those symptoms deserve evaluation. Do not simply stop the medication responsible, in your opinion. Orthostatic symptoms can result from several interacting causes, and the American Heart Association recommends identifying the cause before deciding how treatment should change. The idea of treating systolic pressure into the 120s is not based only on theory. The STEP randomized trial enrolled more than 8,500 adults between 60 and 80 with hypertension. Participants assigned to an intensive systolic target of 110 to below 130 achieved an average systolic pressure of approximately 127.5. Their rate of the trial's combined cardiovascular outcome was 3.5%, compared with 4.6% in the standard treatment group targeting 130 to below 150. Reported dizziness was the same in both groups. That does not mean every 80-year-old should independently chase a systolic pressure of 110. The trial excluded several groups, including people with severe kidney disease, cognitive impairment, certain recent cardiovascular events, and a baseline diastolic pressure below 60. Clinical trials tell us what helped the people who qualified for the study. They do not remove the need to evaluate the individual sitting in front of the clinician. This is why modern guidelines increasingly emphasize frailty, tolerance, standing symptoms, life expectancy, and overall function, not age alone. A goal below 130 over 80 may be appropriate for many people, but treatment may need to be individualized when a person is over 85 and frail, has recurrent fainting or falls, develops symptomatic orthostatic hypotension, lies in institutional care, has a limited predicted lifespan, has advanced kidney disease, experiences repeated dehydration, has significant cognitive impairment, takes several medications at lower pressure, or cannot tolerate a more intensive target despite careful adjustment. The 2025 U.S. guideline identifies additional considerations for people requiring institutional care or living with limited predicted lifespan. European guidance similarly allows clinicians to opt out of the 120-129 systolic target when a patient has orthostatic symptoms, frailty, age over 85, poor tolerance, or limited life expectancy. This is not permission to ignore high blood pressure. It is permission to treat the human being rather than the cuff alone. A surprisingly large proportion of blood pressure confusion begins with measurement technique. Suppose you rush upstairs, sit down immediately, place a cuff over a sweater, cross your legs, hold your arm in the air, talk during the reading, and use a cuff that is too small. The monitor may produce a precise looking number. That does not mean the number is accurate. The American Heart Association's home measurement instructions recommend using a validated upper arm device with the correct cuff size, avoiding smoking, caffeine, alcohol, and exercise for 30 minutes beforehand, emptying the bladder, and sitting quietly for more than 5 minutes. During the measurement, the back should be supported, both feet should remain flat, the bare arm should be supported at heart level, and the person should remain silent. Each time you check, take 2 readings, approximately 1 minute apart, and record both. Do not take 10 readings until you obtain the number you prefer. That is not monitoring. That is negotiating with the machine. Before a routine medical appointment, a structured home record can be more useful than scattered measurements taken only when you feel anxious. The American Heart Association's current log recommends collecting readings for at least 3 days and preferably 7 days. It advises 2 readings, 1 minute apart in the morning and 2 in the evening. A practical record includes the date, the time, the first reading, the second reading, your pulse, whether you had already taken your medication, any dizziness or unusual symptoms, and any unusual circumstances such as poor sleep, pain, illness, or emotional stress. Follow the timing instructions given by your own clinician. Do not delay a prescribed medication simply to create a reading unless it is part of the monitoring plan you were given. At the end of the week, do not fixate on the highest number. Do not celebrate only the lowest. Look at the average and the pattern. Ask, are most systolic readings in the 120s? Are they repeatedly in the 140s? Is the pressure normal while seated but associated with dizziness when standing? Are morning readings much higher than evening readings? Is the pulse unusually slow? Do symptoms occur at a consistent time after medication? Bring the monitor to an appointment so its readings can be compared with the clinic equipment. A reliable pattern makes a better treatment discussion possible. Some people become tense in medical settings. Their office pressure rises while their home readings remain lower. This is often called white coat hypertension or a white coat effect. The reverse can also happen. A person may have acceptable clinic readings but high pressure at home, known as masked hypertension. This is one reason current American and European guidance emphasizes home or ambulatory monitoring rather than making every decision from a single office measurement. Do not use the phrase white coat to dismiss every high office reading. Confirm the pattern. A validated home monitor or 24-hour ambulatory monitor can help your healthcare team determine whether the pressure is truly controlled. Suppose your monitor shows 184 over 122. Do not panic, but do not ignore it. Remain seated and wait at least 1 minute, then measure again using correct technique. If the second reading remains above 180 systolic and or 120 diastolic, contact your healthcare professional promptly. When pressure above 180 and or 120 occurs with chest pain, shortness of breath, back pain, numbness, weakness, a change in vision, difficulty speaking, or another serious new symptom, call emergency services immediately. Do not take an extra prescription dose unless your clinician has given you explicit instructions to do that. Do not ask the person to lie down and sleep it off. Do not drive yourself when symptoms suggest a stroke, heart attack, or another cardiovascular emergency. Now imagine the monitor shows 88 over 54. If you feel faint, confused, weak, nauseated, unusually exhausted, or unable to stand safely, sit or lie down and contact a healthcare professional. Seek emergency help when low pressure occurs, with loss of consciousness, severe chest discomfort, major bleeding, severe breathlessness, signs of shock, or stroke-like symptoms. A reading below 90 over 60 is commonly described as hypotension, but the clinical importance depends heavily on symptoms and cause. 1. Lower than usual reading without symptoms is not automatically an emergency. Record what was happening around the episode. Had you been vomiting? Had you experienced diarrhea? Were you outside in the heat? Had you eaten? Did the symptom occur soon after standing? Was your pulse very slow or unusually fast? Had a medication recently been started or increased? These details may help the clinician find the cause. Instead of asking only, is my blood pressure good? Ask for more precise questions. First, what is my personal target and why? A person with previous stroke, diabetes, heart disease, or kidney disease may have a different risk discussion from someone with no established cardiovascular condition. Second, are my home readings accurate enough to guide treatment? Bring the monitor and your written record. Third, should my pressure be checked while standing? This is particularly important when you have dizziness, fainting, weakness, or falls. Fourth, which symptoms should make me call you and which require emergency help? A written plan prevents panic and reduces unsafe medication decisions. So, what is the safest blood pressure range after 60? For many active and independent adults with hypertension, the general treatment goal is an average below 130 over 80, often with systolic pressure in the 120s, provided it is well tolerated. But do not reduce this entire lesson to one number. Remember these 6 points. First, 140 or 150 systolic is not automatically safe, simply because you are older. Second, the lower number does not cancel a high upper number. Third, 120 over 80 is not a magical score that must appear in every reading. Fourth, lower is not always better when it causes dizziness, fainting, falls, confusion, or weakness. Fifth, seated pressure may not reveal what happens when you stand. And sixth, medication decisions should be based on accurate repeated measurements, symptoms, and professional evaluation, not one unexpected result. The safest pressure protects your brain from stroke. It protects your heart from excess workload. It protects your kidneys from years of vascular stress, but it must also allow you to stand, walk, think clearly, and live safely. That balance is the real target. If this helped you, type 120 seconds in the comments. Share it with someone over 60 who still believes that a systolic pressure in the 150s is simply normal aging. Subscribe to Senior Insight Guide for calm, research-based explanations that help you understand what your health numbers really mean. In the next video, we will examine the 3-minute standing test that may explain why some seniors feel dizzy even when their seated blood pressure looks perfect. Take good care of yourself. You are worth the effort.